Hello and welcome to the GU Oncology Now Community Oncology discussion. Today I'm here with some of my fellow oncologists in New Mexico, Albuquerque and Santa Fe, New Mexico. We'll be discussing mainly issues related to the new sort of paradigm shifts and all of the new the treatment landscape for metastatic castrate-sensitive and metastatic castrate-resistant prostate cancer. Initially, we're going to be introducing everybody, and then we'll kind of get into our discussion after that point. My name is Gregg Franklin. I'm a radiation oncologist here in Albuquerque, New Mexico. I would like to have each of my fellow oncologists introduce, give their name and where they practice in New Mexico, and then we'll start our discussion. So thank you everybody for coming and participating today. Let's start with Scott Herbert, Dr. Scott Herbert.
My name is Scott Herbert. I'm a medical oncologist with Nexus Health in Santa Fe.
And do you specialize and do you see a lot of prostate cancer patients?
I probably see the bulk of prostate cancer in our group, just because I'm male.
Understood. Perfect. Great. And now I'm going to introduce Dr. Jose Avitia. He'll talk about himself a little bit. He's in my group at the New Mexico Cancer Center in Albuquerque, New Mexico.
Hi, I'm Jose Avitia. I'm one of the medical oncologists at the Cancer Center. I'm one of the principal investigators for our prostate cancer group, and I'm happy to be here.
Thank you. Laura?
Hi, I'm Laura Onorato. I'm a physician assistant, and I work alongside with Dr. Avitia and Dr. Franklin at the New Mexico Cancer Center, primarily in prostate cancer care and research.
Thank you. And Kathryn Chan.
I'm Kathryn Chan, medical oncology at the Nexus Health, so I practice with Dr. Herbert over here.
Perfect. So thank you all for coming today. I think what I'd like to do is just briefly start. I know a lot of you, I see a lot of localized prostate cancer patients. I know a lot of you guys, you may see them initially, but let's kind of start with the initial workup of a low-grade prostate cancer, what's thought to be low-grade prostate cancer patients, early stage. How would you work these patients out? What kind of things would you look for in terms of their the characteristics of the biopsies and laboratory work and just the general health of these individuals? Scott, maybe we'll start with you.
You know, a lot of it's just based on the initial biopsy and the Gleason score. This day and age, we see a ton of prostate MRIs even before biopsy, so you can get at least a hint if the seminal vesicles are involved, if there's extracapsular extension, lymph node positivity. But as long as then you can just risk stratify everybody. I think we're using a lot of PSMA PET earlier because we've found that we're picking up local regional lymph nodes a lot better than just typical CT and bone scan.
And a lot of these men most of them are older, and do you look at lifespan and how they're, in terms of deciding what you want to do with treatment, whether it be referring to a urologist or a radiation oncologist? Would you look at their general health?
Yeah, I mean, we definitely do. More than 10 years, less than 10 years kind of thing is sort of the first decision point. We're probably referring a little less for prostatectomy than we used to. I think radiation keeps getting better, and so we tend to lean towards that a little bit. But age of the patient and functional status plays a huge role in that decision. We still fight with PSA screening in our community, yeah. And so not everyone is doing that. And I don't think we're catching as much as we could, you know.
You're diagnosed a little later.
Just a little bit. When we get younger people that have, this is always an interesting problem for me, is that sometimes I'll catch a 52-year-old with very low risk disease. And on the one hand, they're very appropriate for surveillance, right? And on the other hand, you know that whatever treatment that's going to happen in the future is going to be more involved than it would today. So that's always a tricky discussion also.
Perfect. Jose, when you see these patients, do you order any special tests? Do you initially up front look at their, look for mutations or anything else of that nature?
Yes, I mean, I agree with, everything that Scott said. I think the only thing I would add is, I think we're using more genomics, so tests like Decipher to determine whether the 7 can get away with just radiation alone. Do you need intensified treatment with ADT? So I think that's been something that we incorporate into our practice so that we more or less individualize for each patient. I think Scott's absolutely right. When you're looking at the advent of PSMA, so we are catching distant disease, oligomets, that our radiation oncology team like yourself can target these patients a little bit, effectively. And so I think that's been something that the PSMA has definitely added to our practice. So I think those are the big nuances, I think, to add to what Scott's already said.
And Laura, when you have earlier stage patients, I know it's not quite the bone metastasis, but what do you talk about with them as sort of an adjunct to what Dr. Avitia says?
Well, we know that prostate cancer care and treatment can increase cardiovascular risk and can have impact on bone health. And so I think my role in supporting their care is to optimize their cardiovascular health, their metabolic health, even talking to them about sexual side effects and their ability to have function preserved. So it's my job to support their health in that regard and also help them on their road with treatment.
A lot of times you hear that a cardiac diet is a prostate cancer, is a good prostate cancer diet as well.
Yeah.
And reducing sugar, decreasing inflammation, are those things that you also, or that patients?
A lot of our patients come to us already with comorbidities, hypertension, diabetes, chronic kidney disease, and so it can be challenging, and it's definitely important to emphasize that they need to, in combination with us and their primary, that we need to control for those type of risk factors, treat them, and also encourage them to maintain good physical activity and good nutrition with plenty of protein in their diet, because we know that they're at risk of losing bone mass and muscle mass and strength as they go through treatment. So
Perfect. Yeah. Thank you so much. Kathryn, just a quick question. So have you been seeing, well, let me rephrase it. Do you think that 100% or most of these patients, even on the early stage, are getting PSMA scans? Or do you still get a lot of referrals where they've ordered conventional scans, bone scans and CTs?
Yeah, a lot of the referrals that come to our clinic obviously already have a diagnosis of prostate cancer, so they're mainly either coming from the urologist or the primary care. If they come from the urologist, most of the time you'll have an MRI of the pelvis already. If they're coming from the primary care, it's pretty much PSA elevation, and they're sending the patients to you, and the medical oncologist now becomes the gatekeeper of what happens next. So, as far as imaging is concerned, if I get it from the get-go as the gatekeeper, depending on the MRI findings, I don't usually do, and if we have a biopsy that confirms a diagnosis, I generally start with conventional imaging, your CTs, and then bone scan for staging, initial staging.
And usually in the more, say, intermediate risk or higher.
Yes.